Thank you so much for the kind introduction. First of all, I have no financial conflicts of interest. I do have some active grant funding from the Department of Defense and also Pennsylvania's Department of Health. And I'm on the Consumer Advisory Board for the VA and DoD's long-term impact of military relevant brain injury consortium. I also have to note that the contents of this presentation do not represent the views of the Department of Veteran Affairs or the United States government. My objectives for today is to first of all give a brief introduction to the current state of TBI diagnosis, intervention, and prognosis as a background for this talk. And then we're going to move into a review, an overarching review of some of the existing literature looking at dementia risk in TBI survivors, followed by a review of the evidence suggesting cerebral microvascular pathology is a common endophenotype between traumatic brain injury and dementia, and then explore some avenues for future research for which myself and my lab are pursuing. So to begin with, traumatic brain injury has multiple different definitions, but the DoD and VA say TBI is defined as a traumatically induced structural injury and or physiological disruption of the brain function as a result of an external force. This is extremely heterogeneous, both in the mechanism of TBI exposure, the underlying molecular pathology, and the long-term outcome. So, you can have a traumatic brain injury from a severe motor vehicle accident, from a fall downstairs, from a blast, like our military veterans are experiencing, from repetitive trauma like boxing or soccer. So there's multiple different mechanisms. And I'm sure most people here are familiar with the fact that we clinically diagnose a traumatic brain injury as either mild, moderate, or severe based on some specific criteria, including structural imaging, the presence or absence of a loss of consciousness, and if so, how long, any alteration of consciousness and how long, post-traumatic amnesia, which, the board's question is, this is the duration of post-traumatic amnesia is the most accurate predictor of long-term outcome. And then there's the Glasgow Coma Scale, which has fallen out of favor. And, since I think 2015 or 2016, the DoD and the VA specifically recommended against the use of the Glasgow Coma Scale in any type of prognostication or diagnostics for traumatic brain injury. So as a clinician, we group this as mild, moderate, or severe based on this criteria. Now, both in the civilian world and in the military world, the overwhelming majority of all traumatic brain injury exposure can be classified as mild. These are the latest numbers from the Department of Defense. From over the last 20 years, there's been over 430,000 service members officially diagnosed with traumatic brain injury, of which 82% are mild traumatic brain injury. And according to the CDC, about 150 Americans die every single day from traumatic brain injury related events. And those who survive a traumatic brain injury can face effects that last from a few days to the rest of their lives. So everyone that's in the field of physical medicine and rehabilitation knows that there is a plethora of symptoms that one can experience after a traumatic brain injury exposure, which varies widely. There's physical symptoms, cognitive symptoms, and behavioral or emotional symptoms. If we look at this, some of the most common are there's cognitive complaints, there's ocular motor problems, there's problems with balance, the autonomic nervous system, and some others. And this really spans the gamut from mild TBI to severe TBI, and it's really on a spectrum. And any given patient might have variable amounts of ocular motor versus balance versus cognitive deficits. And it's really hard to predict how a given patient that's presenting in the acute phase is going to be presenting in the subacute to chronic phase. There was just a recent paper published in Neurotrauma. It's just out electronically right now by Mary Jo Pugh and her colleagues at the Salt Lake City VA and the University of Utah, where they're trying to look at distinct TBI outcome phenotypes and how there's basically a wide variety. So it's really hard to predict. So, acutely, we have the TBI, which we can classify from mild TBI to severe. Then if we look at the days to up to a month post-injury, there's a variation in the phenotypes. And then if you go out to the subacute phase, let alone the chronic phase, patients continue to diverge. And so it's really hard to predict which patients are going to fall in which long-term category. Now, as a brain injury doc, when I'm seeing patients, especially in the military setting, where patients have had their brain injury exposure usually several years ago, the biggest long-term outcome that they're looking at is dementia. But before we get there, what I've presented so far from TBI diagnosis and then these phenotypes, the real thing is there's a big elephant in the room here in the field of brain injury medicine, namely that traumatic brain injury is a non-specific diagnosis. And this leads to non-specific treatment recommendations, which lead to non-specific outcomes. So let's say instead of a brain injury doc, I was an oncologist, and a woman found a lump in her breast and she came to see me and we did a fine needle aspiration. And so now the woman is sitting in our office and we say, I'm sorry, Miss Smith, but you have cancer. And when after the shock, when she says what type, we say moderate. And based on this moderate cancer, we're going to give chemotherapy regimen X, and we're going to basically hope for the best and look at the long-term outcomes. There's a lot of problems with that, right? And that's not what we do in oncology at all. Instead, they're going to look at the specific receptors that are expressed, whether the tumor cells express like Herceptin or estrogen, and then there's going to be targeted chemotherapy for that based on the specific endophenotype or that subdiagnosis, not just a global breast cancer. And so in the brain injury field, really, we are not giving specific diagnoses. And therefore, there's a huge problem with nonspecific treatments and nonspecific outcomes. So again, I had jumped ahead before, but the majority of patients in the subacute to chronic phase are really asking, am I going to get dementia because of my TBI exposure? And is there anything that I can do that's evidence-based to reduce the risk for dementia as I age? And especially in the military population, I mean, I'm confronted with this on a daily basis in clinic. There's tons of stuff in the news. This is from 3 years ago, a 60 Minutes interview where, they're talking about combat veterans coming home with chronic traumatic encephalopathy or CTE. And, this is a disease and a problem that we're going to be dealing with for decades. It's a huge public health problem, a huge problem for Veterans Administration, and a huge moral responsibility for all of us. Okay, so with this background, let's review some of the existing literature looking at the risk of dementia in TBI survivors. So there's been several well-done studies, but the first one we're going to look at is a study that was actually done out of the Hopkins Bloomberg School of Public Health with Andrea Schneider. So she was an MD PhD student at Hopkins, and she's since moved up to Penn as an attending. So she's a neurocritical care physician that has a PhD from the Bloomberg School of Public Health. So she just published this paper a few months ago in the prestigious Journal of Alzheimer's and Dementia, where they looked at the 25-year risk of dementia in about a little over 14,000 participants in the atherosclerosis risk in communities study. So here they looked at, first of all, they did not parse out whether a brain injury was mild, moderate, or severe. They just had the ICD-9 and 10 codes, and it was traumatic brain injury, yes or no. And then there was dementia codes. And what they were able to show is clearly there was an increase in the hazards ratio of dementia diagnosis from those patients without a history of TBI versus a history of one traumatic brain injury, or substantially greater if you had 2 or more head injuries. But again, this wasn't parsed out as mild, moderate, or severe. If we look at this as a function of age, really as a function of time from when the person was initially enrolled into the study over the 25 years, you can see with time, there's an increased incidence in dementia diagnosis and If you don't have any traumatic brain injury, still it goes up. If you have a single traumatic brain injury, there's a statistically significant increase. And if you have two or more, then you're really at a statistically significant increase. And they concluded that their findings confirm the association between head injury and dementia risk and expand the literature by providing evidence for a dose-dependent relationship, which notably exists, that the association is stronger amongst women versus men and amongst whites versus blacks. I didn't show the data here, but this is a very interesting study for people on the call if they're interested in looking at this. Then there was another study by Christine Yaffe out at UC San Francisco and her colleagues that was published in JAMA in 2018. And this was a huge study in veterans. It was a retrospective propensity matched cohort study of more than 350,000 veterans with and without traumatic brain injury. And they looked at TBI diagnoses from two sources. So when a veteran comes into the VA after getting off active duty, they go through a whole bunch of screening with their primary care doctor. And one of them is if they screening to see if they've ever been exposed to traumatic brain injury while in the military. If they screen positive, they have to see a brain injury doc like myself, and they undergo a comprehensive TBI evaluation. So they were able to search the national database to look at all the diagnoses of traumatic brain injury using that TBI second level evaluation, as well as all the patients that came into the VA that didn't go through that pipeline. So they had 178,779 patients that were diagnosed with traumatic brain injury. And then what they did is they got an equal number of propensity matched comparison groups. So then they looked at patients that were in the VA from across the United States from 2001, October 2001 till September of 2014. And all those patients that did not have a history of TBI exposure. And then they matched them, propensity matched them based on the same other comorbid diagnoses and different demographics. Okay, and the mean age was about 49.5 years at baseline when they were in the study. So what did they show? First of all, if we just look at the unadjusted risk of dementia by TBI severity. So first of all, if they looked at all patients that had a history of one traumatic brain injury or more, okay, the hazards ratio of dementia diagnosis was 3.41. Then they had three sub models. So the first model is they adjusted for demographic characteristics such as sex, race, education, and income. Then the second model was they adjusted for everything in model one, but also comorbid diseases like diabetes, high cholesterol, heart attack, stroke, and peripheral vascular disease. And finally, the third model was taking into account adjustments for models 1 and 2, but also adjusting for psychiatric comorbidities such as anxiety, PTSD, substance use, tobacco use, and sleep disorder. So what you can see, no matter which adjustment they did, clearly there was about the same hazards ratio for dementia diagnosis with TBI exposure. If they then parse this data out based on the severity, so we have mild TBI without a loss of consciousness, mild TBI with a loss of consciousness, mild TBI where the loss of consciousness status was unknown versus moderate to severe, there's basically a dose effect here where as you go from more mild level of brain injury to more severe, the hazards ratios get greater. Further, if you look at this as a function of age, so again, we can see the black line here. This is those patients without TBI exposure. As you age, there's an increased cumulative incidence of dementia diagnosis. And then as you have mild TBI without loss of consciousness, the whole way up to moderate to severe TBI, there is a statistically significant increase. Now, it's important to note here, from a research perspective, clearly there's an increase. From a clinical perspective, we have to remember that there's a difference between the absolute versus the relative risk. So if we look here at the total numbers, a total of 4,698 veterans, or about 2.6% without TBI exposure, developed dementia, compared to about almost 11,000 or 6.1% of those with TBI exposure. So these are two of the primary studies looking at this. And if we look at some meta-analysis, so there was a big dementia prevention, intervention, and care, the 2020 report of the Lancet Commission, which was published, and they did some meta-analyses looking at the relative risk of all-cause dementia as an association with all severity midlife traumatic brain injury. And if they looked here, there was a number of well-done, high-quality studies, of which the cumulative risk ratio of all of these was 1.84 increased risk of developing dementia if you had a TBI exposure in midlife. But again, this was all TBI. So if we look at the most common, which is just mild traumatic brain injury, there was another systematic review and meta-analysis recently done and published in the Journal of Alzheimer's and Dementia last year, where they looked at 5 well-done studies, and they determined the overall odds ratio of about 1.9 to about 2 of developing dementia after remote mild traumatic brain injury. Okay, so with that background, we're now going to let's look at some of the evidence suggesting that cerebral microvascular pathology might be a common endophenotype between TBI and dementia. So again, we talked about 10 minutes ago about the fact that it's my belief that traumatic brain injury is a non-specific diagnosis. So we're not looking at the actual endophenotypes here. And yes, there's a lot of variation. You could have subarachnoid, subdural, you can have intraparenchymal hemorrhage, but the most common thing that you have is diffuse injury, namely diffuse axonal injury and diffuse microvascular injury. So if we look at diffuse axonal injury first, clinically, when we're looking at a patient that might be still in a disorders of consciousness program that we're seeing, that we're trying to figure out, are they, vegetative or minimally conscious? And there wasn't much bleeding, but we get advanced MRI. So, what do we teach the residents? We're getting advanced MRI with susceptibility weighted and gradient echo sequences. So here you can see this was published, a 17-year-old female, 10 days post a motor vehicle accident with a severe traumatic brain injury. And we're looking at all these black dots here, okay? And this is MRI evidence. This is a MRI susceptibility weighted imaging. And clinically, we're going to say, this is evidence for diffuse axonal injury. If we look under the microscope in patients that succumb to their injuries, the neuropathologists are looking for staining for the amyloid precursor protein, or APP. This is the neuropathological hallmark of diffuse axonal injury. Here's 2 cases. So one, this is an 18-year-old male that passed away 10 hours after an assault. And we can see under high magnification here, you can clearly see the undulations in this axon as there was disruption to the microtubules, and there was a backup of the amyloid precursor protein, which is what we're staining for here. So all this brown staining is APP staining demonstrating diffuse axonal injury. Same thing here, this is a 22-year-old female, 22 hours post a motor vehicle accident. Same thing, you have disruption of the microtubules, buildup of APP, and you have nice staining here of this undulated axon of diffuse axonal injury. Now, about 25 years ago at the University of Pennsylvania, Dr. Douglas Smith, Dave Meany, and colleagues in neurosurgery and biomedical engineering developed a large animal swine model of diffuse axonal injury. So what happens is you have rapid rotational acceleration, deceleration. So there's no head impact. Literally the heads move from one side to the other in a split millisecond. It's like if you're driving 60 miles an hour down the highway in a car and you got a seatbelt on and you slam on the brakes. Well, what's going to happen? Your body's going to go against the seatbelt, right? Because your body has a different density than the car. So same thing sort of happens in your brain. You can think of it the same analogy. You have white matter, you've got gray matter, you've got cerebral spinal fluid. All of those things have a different density. So when you undergo rapid rotational acceleration, deceleration, the different parts are going to accelerate and decelerate at different rates. And this is really what produces the stress and strain and causes the diffuse injury in a predictable pattern based on the level of where the force was coming in, the trajectory of how the force was coming in. So they map this, and we can do this in the coronal plane, the sagittal plane, or the axial plane. And you're going to get varying amounts of pathology. If we look here at the gross pathology, so this was some of my colleagues, Dr. Casey Cullen here. He's the director of our VA Center for Neurotrauma, Neurodegeneration, and Restoration that I'm a part of. So, okay, this is the gross pathology of some of the pig brains. So if we look at a sham control that just underwent anesthesia, didn't actually receive a traumatic brain injury, when the brain is removed, you can see there's a pristine brain. There's no gross pathology. There's no bleeding. If we do a coronal injury of about 190 radians per second, this is our model for concussion. There again, there's no gross pathology. There's no gross bleeding or anything. When the pigs come out of anesthesia, it's very hard to tell any clinical difference between the controls. It'll be a different story when we look under the microscope in a second. As we increase the injury in the coronal plane, now we're starting to get into the more moderate range of brain injury, where if this were a human and we did advanced neuroimaging, we would see some subarachnoid hemorrhage here. You can see here the subarachnoid blood, and also down here, the brainstem region. If we go from the coronal to the sagittal plane, now even at a lower acceleration here, we can see much more subarachnoid hemorrhage. The bottom line is we can scale this the whole way from concussion up to severe brain injury with disorders of consciousness. And one of my colleagues at Penn now just got a recent grant where they're doing severe disorders of consciousness, and they're surviving the pigs long-term to try to look at long-term outcomes, which is more relevant to rehabilitation. So, I mean, the whole 9 yards from, there's the 24-hour EEG and neurosurgery suite, and the pigs have a bolt in their head, and basically they're treated just like they are in a neuro ICU in a clinical setting. If we look under the microscope, even in concussion, or the mild end of the spectrum here, where we had normal gross pathology, you can see there's extensive diffuse axonal injury in the white matter tract. So again, we're staining for the amyloid precursor protein, and panels A and B are from the pig, and panels C and D are human. And if you're looking under the microscope at high magnification of diffuse axonal injury, you cannot tell the difference is identical pathology between human versus these pigs. If we look at this zoomed out, so now we're looking at a whole coronal section here, and all of this blue staining is staining for APP. So again, we can see here you've got the lateral ventricle, you've got the white matter, gray matter around it, and you have most of the pathology in the leading hemisphere in the periventricular white matter, where there's that significant difference of density between the cerebrospinal fluid and the white matter. And again, here high magnification of diffuse axonal injury. Okay, so this is what we all learn about for the boards, and when we think about diffuse injury, we're always thinking about diffuse axonal injury. However, let's go back to this MRI where we're looking at clinically the susceptibility weighted imaging. So again, we clinically say, this is evidence of diffuse axonal injury. But what we're really looking at is diffuse vascular injury. All of these black dots are hemosiderin deposits of microvascular injury. So we're looking at microvascular injury and we're inferring diffuse axonal injury. This is a nice illustration from two of my colleagues at Penn looking at what happens to the microvasculature in the brain whenever you have traumatic brain injury. So again, most people on this call in physiatry are probably pretty familiar with the concept of the blood-brain barrier, and the brain tightly regulates what can get in and out of the brain. So, it's very hard to get drugs and different things from the blood into the brain parenchyma. When you have traumatic brain injury, there's multiple different disruptions of the different layers here of the neurovascular unit and the blood-brain barrier. In the end, you get a dysfunctional blood-brain barrier where you can have extravasation of blood proteins into the brain parenchyma, which causes a host of downstream effects. A picture's worth 1,000 words here. So this is scanning electron micrographs of two brains. So on the left, we have a control brain. So we're just looking here This is a special technique where we're just looking at basically the arterial tree. So we have, you can think of it as, the bigger trunks and stuff to some of the branches to the tiny, tiny little branches as we go down into the brain parenchyma. So this is a nice, healthy brain microvasculature where the person passed away from something other than traumatic brain injury. And then if we look over here on the right, this is a person with severe traumatic brain injury. And again, you can just look at the picture and see the vast difference between all the vascular structures here from the TBI patient versus the control. Yeah. So one of our colleagues and collaborators, Dr. Willie Stewart and colleagues over in the United Kingdom in Glasgow, they have one of the world's largest banks of brains of people that were exposed to traumatic brain injury, including moderate to severe brain injury and repetitive mild brain injury. And they didn't pass away at the time of their injury, and they survived for several years where they were followed clinically. And then when they passed away, their brain was donated to the bank. So they published a study, an autopsy study back in 2015, where they looked at a whole cohort of brains of long-term survivors of brain injury versus control. So again, if we look here, this is one example of a 20-year-old male that survived 2 days post an assault. And what we're looking at is staining for something called fibrinogen, which is a large protein that's in the blood, which is normally confined to the blood and does not get into the brain when you have a healthy, intact blood-brain barrier. When you have disruption to the blood-brain barrier, then basically the blood contents are able to extravasate into the brain parenchyma without control. And that's what you're seeing here. All this brown staining is extensive microvascular pathology in the brain 2 days post an assault in this 20-year-old patient with severe brain injury. On the right, we're looking at a 60-year-old male from their archive that survived 18 years after a fall. So the person had a fall, had a moderate to severe brain injury, but survived, lived 18 years, died from another cause. And at autopsy, you can see there's still extensive vascular pathology, microvascular pathology with extravasation of fibrinogen into the brain parenchyma throughout the brain. If we look here at sort of high magnification, you can see where let me see if I can get it. My laser pointer is right in the center of a blood vessel, and you have extravasation outwards 360 degrees of fibrinogen leaking through that vessel that has a disrupted blood-brain barrier. So this is on autopsy. What if we look at some functional studies? Dr. Kim Kenny at the NIH and USIS and Ramon Diaz-Aristia, who is now at Penn, they did a very interesting study. This is their preliminary results, and they've now expanded it, where they're looking at functional cerebral vascular reactivity in patients surviving a moderate to severe brain injury 6 months after their injury. So there's a special type of MRI called BOLD, which is blood oxygen, I think, level dependent MRI. And what's done here is the patients they have a mask on, and the scientists can vary the concentration of carbon dioxide in the air that they're breathing. So if we look here at the right of this histogram, the sort of blue healthy control line shows what should normally happen as you alter the concentration of carbon dioxide. You're going to cause vasoconstriction or vasodilation, and you're going to have changes in cerebral vascular reactivity. And so you see this nice healthy curve as they change the amount of carbon dioxide, you're having vascular reactivity. The red is 6 months after moderate to severe brain injury. And basically the gist is that there's a disruption of the ability of the microvasculature to respond to that changing concentration of carbon dioxide. So there's a functional problem with the microvasculature in the brain. Switching from moderate to severe brain injury to mild traumatic brain injury concussion, and from human to pigs, I showed you before there was a ton of research done over the last 25 years looking at diffuse axonal injury in these pigs models. But recently, Dr. Victoria Johnson and colleagues at Penn published a paper in 2018 where they looked at the diffuse microvascular injury in mild traumatic brain injury in these pigs. And what we're looking at here, everything that's highlighted, is the quantification of fibrinogen extravasation into the brain parenchyma up to 3 days post single concussion. So they did this at 6 hours, 24 hours, 40 hours, and 72 hours. And we're systematically looking through the brain, and they're looking at the widespread microvascular pathology. Again, here you can see, let's see, look here, see, this is the low mag, this is the leading hemisphere periventricular range. If we look at high magnification, right where you have the border zone between the lateral ventricle and the surrounding periventricular white matter, you have a lot of the microvascular pathology here. If we look at this side by side in two serial sections, so a few microns apart from each other. So the first section was stained for fibrinogen, looking at diffuse vascular injury, and the second section was stained for APP, looking at diffuse axonal injury. And the bottom line is there is overlap where you had the most mechanical forces in the periventricular white matter based on this coronal input of the force of the pathology, and you have the same corresponding microvascular injury, but you have injury diffusely throughout the brain. Now, my lab, we were looking at this, at quantifying this longer term, going out to 1 year. So if we look on the left, again, this is 7 days after a concussion. We see a nice blood vessel here. There's disruption of the blood-brain barrier, and there's extravasation of fibrinogen into the brain parenchyma. And you can see several neurons are taking up this fibrinogen. They're being darkly stained. If we look here on the right, this is a technique that we did to systematically quantify the degree of blood-brain barrier disruption in a scientific manner where we can quantify and be less biased. So you can see here, here's gray matter. This is the corpus callosum. You can see the nice border zone. Now we're in the white matter. If we look here, here's a nice healthy blood vessel. There's a nice healthy blood vessel that's intact. All the blood, and in this case, fibrinogen, are contained within the blood vessel. Here's another one. But if we look here, there's a blood vessel running through this field, which has disruption of the blood-brain barrier, and there's a leak cloud of extravasation of blood out. If we quantify this, so now we're looking at low magnification. All of these purple dots are all the regions where there was extensive microvascular pathology. So if we quantify this, we replicated our colleagues' initial results that in the acute phase up to 3 days post-injury, yes, there is a disruption of the blood-brain barrier. But if we go out to 1 month, let alone 1 year, there's been healing of the blood-brain barrier, and we cannot tell a statistically significant difference from the sham control animals. Going back to the philosophy or the principle that the body has the innate ability to heal itself and given the right conditions. So when you have a trauma, instantaneously the body is trying to heal. There might be some persistent pathology in a mild level of injury, but in a single mild injury, it seems like there is repair of the microvasculature. I'm not presenting it here, but some of my colleagues are also doing the same thing in amyloid precursor protein, APP, and they're showing the same thing, that when you have a single concussion, yes, you're having a lot of diffuse axonal injury acutely, but the pathological hallmarks of that fade with time, and by about 1 month post-injury, it's very hard to tell a difference from the control animals. Okay, so that was a brief review of evidence suggesting that there's cerebral microvascular pathology in traumatic brain injury. Now let's look at dementia. So in the early 1900s, the view of dementia was largely that it was a vascular phenomenon. And then the pendulum swung to the 1990s, where it was all about, its pathological proteins like tau and amyloid. And then over the past 20, 30 years, the pendulum has really swung back to there's a ton of vascular pathology input to dementia, if not microvascular pathology driving this dementia diagnosis. So there's been a multitude of preclinical and clinical studies. This is one review that was published in Physiology Reviews about 2 years ago. It's a very well done review looking at all the evidence that has accumulated to basically say when you have a cognitively normal person, you have a healthy, intact blood-brain barrier. Once you start having a little bit of disruption of the blood-brain barrier, if we're looking at advanced, imaging, susceptibility weighted MRI, just regular T2 white matter hyperintensities, if we're doing advanced things like dynamic contrast enhanced MRI with and without contrast, where we're looking at breaches in the blood-brain barrier, versus maybe some people on this call have seen the beautiful, pretty diffusion tensor imaging or tractography MRIs, looking at all the white matter tracts. If we look at this advanced MRIs and functional MRI, we're starting to see problems. This is around the preclinical or mild cognitive impairment stage. And by the time you get to early dementia, clinical diagnosis of early dementia, there's extensive blood-brain barrier pathology. And finally, in fulminant, progressive Alzheimer's and other dementias, there's extensive blood-brain barrier pathology. If we look at one group, so there's a big famous group out at UCLA by Dr. Zlokovic. So his team has published a couple of landmark papers in the past couple of years. And one of them, they looked at dynamic contrast enhanced, or DCE MRI. So this is MRI done with and without contrast. And they're looking at 3 cohorts. So they're looking at non-cognitively impaired, or NCI, young adults, non-cognitively impaired older adults that have been officially diagnosed with mild cognitive impairment, and then a group of a control group that has multiple sclerosis without cognitive impairment. And then they're specifically looking at the hippocampus. And so they get these pretty maps here. They're looking at basically the permeability here of the blood-brain barrier. And so blue is very little, and as you get towards more green, yellow, red, you're having a lot more blood-brain barrier pathology. If you quantify this, you can see there's a stepwise approach. So in young, non-cognitively impaired individuals, they largely have an intact blood-brain barrier. As you get to older individuals that have normal cognition, still just as a function of age, you're having increased permeability of the blood-brain barrier in the hippocampus. And by the time you get to the official diagnosis of mild cognitive impairment, there's again a statistically significant increase in the permeability of the blood-brain barrier in the hippocampus. So if we go back to our pigs and we look at some preclinical models, so I've been involved in the TBI pig work at Penn, but there's our colleagues, Robert Walensky and colleagues at Penn that are cardiologists and cardiothoracic surgeons. And they developed a diabetic hypercholesterolemic pig model. Now, they specifically developed this to generate atherosclerosis so they could do trials and stuff for stents and cardiac drugs. So what they do is they take pigs that are 6 months old and they induce diabetes, and then they give them a poor diet to give high cholesterol and hypertension. And after 3 months, so you can look here, here's one of the coronary arteries, and you're starting to see a nice atherosclerotic plaque here. By 6 months post-injury, there's extensive atherosclerosis. So one of my collaborators, Dr. Robert Nagel and Nimesh Acharya over at Rowan University in New Jersey, they initially got these brains and they looked at, okay, well, what's going on in the brain? So if we look here on the left, this is one of the pigs that was fed a normal diet and was not hypercholesterolemic or diabetic. And you can see this time, instead of staining for fibrinogen, they're staining for IgG, but it's the same concept. All the IgG should be contained within the vasculature. And you can see all these nice capillaries here in the brain, and all of the IgG staining is within the vasculature. There's no breach in the blood-brain barrier, and there's no intraparenchymal staining. However, 6 months after being diabetic hypercholesterolemic, you're already seeing breach in the blood-brain barrier and extravasation of these blood products into the brain. This next slide is unpublished data from my lab that we used for a grant we just submitted, where we got some of these brains. And so panel A is, we're looking at a single animal. This is one animal's brain that had a concussion 2 concussions 1 week apart. So it had a mild traumatic brain injury or concussion. 7 days later, had another mild traumatic brain injury or concussion. And it was survived 1 month. And at 1 month, we can still see there's a lot of microvascular pathology here in this repeat mild TBI model. Panel B is 6 months after being diabetic hypercholesterolemic, and C is healthy control, where you have no TBI, no diabetes, or hypercholesterolemia. So in both cases, whether you have poor modifiable cardiovascular risk factors or you have repetitive mild TBI, you're having breach in the blood-brain barrier. It's a common endophenotype. Okay, so all of this is well and good, but just like in the clinical realm, you can't really confirm Alzheimer's or other dementias until death when the pathologists do an autopsy. So there was a lot of this, studies supporting the evidence that there was microvascular pathology in dementia, but it wasn't until about 2013 when a big, large study was published from the National Alzheimer's Disease Coordinating Center, where they looked at 4,629 cases of autopsy-confirmed Alzheimer's disease. And they did a reanalysis and they looked at these brains and they showed that 80% of all those patients that were pathologically confirmed to have Alzheimer's disease had comorbid vascular pathology in the brain. So taking this together, again, Christine Yaffe and her group back in 2014, they did a look at traumatic brain injury and the risk of dementia in older adults. And this time they did a retrospective cohort study looking at 188,000 US veterans age 55 or older who had at least one inpatient or outpatient visit during a baseline from 2000 to 2003, and also follow-up between 2003 to 2012 periods. And they did not have a dementia diagnosis at baseline. Veterans had a mean age of 68 years old, and during the 9-year follow-up, 16% of those with TBI developed dementia compared to only 10% without TBI. But most importantly, the biggest thing from the study is that there was an additive effect between TBI and other conditions on the risk factor of dementia. So if we look here at the cumulative incidence of dementia in their cohort, the green line on the bottom is those patients without a history of TBI exposure, and the red line is those with a TBI exposure. But importantly, if they look at cardiovascular disease also, so the green line on the bottom, this is no traumatic brain injury and no cerebral vascular disease. The red line is patients diagnosed with cerebral vascular disease only. This blue line is traumatic brain injury only. And then this dark red or maroon line is when you have a dual diagnosis of traumatic brain injury and cerebral vascular or cardiovascular disease. Now you really significantly increase your risk for dementia diagnosis. Okay, so with this background, let's, how are we exploring some of these future research in the scientific domain? So we have a grant in my lab that we just got a great score, and we're anticipating getting funded here in the next couple of weeks. And our overall central hypothesis is that there's cerebral microvascular pathology is a common endophenotype in both TBI and dementia. And while innate repair mechanisms may promote healing of traumatic microvascular pathology following TBI exposure, the presence of a poor cardiovascular risk factor profile over the decades after this is going to promote progressive non-traumatic microvascular pathology, ultimately contributing to the significant increased risk of age-related cognitive decline or dementia. So we're specifically looking at mild traumatic brain injury, but we think that there is an acute pathology, but then there's largely some healing, maybe not the back to baseline. Obviously, if you have multiple repetitive head injuries, you're going to increase your risk more. But then really, if you have head injuries when you're 20 or 30, well, what's going on over those next 30 or 40 decades are really what we think is going to be driving a lot of the pathology. Looking at a preclinical study planning, not for the grant I was talking about, but for other grants we're working on, both using pigs versus using special mice. Rodents don't have the same lipid profile as humans, so you have to use a genetically altered animal that's fed a bad diet so that you can induce high cholesterol and things like this to get atherosclerosis. But we're looking at models where we can do single versus repetitive mild traumatic brain injury, and then induce either healthy cardiovascular risk factors versus poor cardiovascular risk factors over a period of at least 6 to 12 months. And then look at from pathology to blood-based biomarkers to neuroimaging. What I'm very hopeful that our grant is going to be funded is leveraging the Limbic Sensi database. They currently have 1,600 patients enrolled. These are all combat veterans from Iraq and Afghanistan with mild traumatic brain injury only exposure. And what we're going to be doing is looking at 2 advanced neuroimaging markers of cerebral microvascular pathology, a special type of white matter quantification versus a special type of diffusion MRI. And we're going to look at fixed risk factors versus age, sex, and then their combat-related mild TBI exposures versus a panel of modifiable cardiovascular risk factors, including physical activity, sleep, smoking, alcohol, diabetes, cholesterol, blood pressure, and BMI. And the 2 neuroimaging methods we're using, the first one is this Bianca. It's a method that basically combines T1, T2 flare, and the DTI FA or fractional anisotropy images to generate a probability map of white matter hyperintensities. And there was an initial study published in JAMA where I think this is very interesting, although it's a preliminary study. They took 125 young adults that were seemingly healthy with no evidence of cardiovascular disease, no clinical evidence. And they looked at a variation of the American Heart Association's ideal cardiovascular health index. So we look here, this person was a little bit overweight, a little bit high cholesterol, 21-year-old male, a little bit overweight, a little high cholesterol, a little bit of high blood pressure. This is not exercise, it's just like actigraphy and stuff. So about 14 hours per week of moderate activity, moderate to vigorous. Their peak blood pressure at exercise was 200 over 70. This person drank more than 8 drinks per week. They were not a smoker. And already at age 21, they had over 31 white matter lesions measuring more than a millimeter. If we look at this person's brain, look at the extensive white matter pathology already in this asymptomatic 21-year-old. In contrast, here we have a 24-year-old female that's normal body mass index, better, normal blood cholesterol, better ambulatory blood pressure, 1.5 times the amount of moderate to vigorous activity per week as the person above. Peak blood pressure at exercise was only 180 over 90 and drinks less than 2 drinks per week as a non-smoker. And this person only had 8 white matter lesions measuring more than 1 millimeter. Finally, more sensitive than looking at white matter hyperintensities is looking at something called diffusion MRI-based free water volume fraction analysis. So this is a special technique where we're looking at basically the free diffusion of water, which is an indicator of microvascular injury in addition to some other axonal pathology, versus fractional anisotropy. This is the FA, which is what you normally see when you're reading MRI studies in mild traumatic brain injury or any brain injury, and they're looking at, diffusion tensor imaging. That most of the time they're looking at the FA. So here's a study that was done out of the Framingham Heart Study where they looked at this measure of carotid to femoral pulse wave velocity, a measure of arterial stiffness or cardiovascular disease. They looked at the association of that versus free water and FA pathology in 2,422 participants. And basically what you can see, the gist here is you're having an increase in free water and a decrease in FA. So there's an increase in the free water and a decrease in fractional anisotropy. If we look at traumatic brain injury doing the same advanced neuroimaging, on the left, this is a pilot study that was done in 40 patients in the nationwide track TBI study. 2 weeks after concussion, same thing. We're seeing an increase in free water and a decrease in fractional anisotropy. So this is mild traumatic brain injury where we're seeing the same pattern, though less extensive than in the cardiovascular disease above. And then here on the right, again, this is the same neuroimaging modality, but now we're looking at moderate to severe traumatic brain injury patients that presented to Moss Rehab. So this is my collaborator, Dr. Ragini Verma's lab at Penn with John White from Moss Rehab. So they looked at moderate to severe patients 3 months post-injury. Same thing, they're seeing an extensive increase in the free water volume fraction in these patients' brains. Okay, last thing to sum this up, if we go back to the clinical realm besides research, so we still go back to the question of most of my patients that are asking me, am I going to get dementia? And what can I do about it? And the gist of what I tell them now, based on the current best available balance of evidence, is you cannot change the fact that you had a TBI exposure, but you can change your modifiable, largely cardiovascular risk factor profile. And being, like I said in the beginning, I was a Marine, so military person when in the VA, I like to use this quote from the Chicago Tribune for my veteran patients, that the idea of preventative medicine is faintly un-American. It means first recognizing that the enemy is us. So I try to get them to incorporate secondary prevention post-TBI exposure with lifelong neurorehabilitation based largely on the American College of Lifestyle Medicine, including nutrition, exercise, unwinding, restore, and optimization of cognitive reserve. And I also point them to the recent 2020 Dementia Prevention, Intervention, and Care report by the Lancet Commission, noting that there are at least 12 risk factors that the person can modify that might prevent or delay up to 40% of all dementias. And namely, that yes, traumatic brain injury is on here, but it's really only 3 to 4%. And all of these other things, including smoking, depression, social isolation, physical activity, inactivity, diabetes, hearing loss, all these other things, high blood pressure, obesity, play a bigger role when you add it all up, and these are what's in their control. So with that, I'm going to stop and take any questions. Are there any questions or?
It's a quiet group today.
Sorry, maybe I went too fast or too much info.
If it's all right with you,
Oh, wait, you're muted. I'm sorry.
Sorry, that was accidental. I said we could share your contact information in case people need a little time to think it over. And if they have questions, they can reach out to you.
Yeah, absolutely.
I think that work you're doing is really fascinating and also timely, given all of the interesting stuff that's going on around brain injury and repeated injuries, especially over the past several years. And thank you for presenting today and for joining us virtually.
Absolutely. It was my pleasure. Thank you so much.
I just wanted to say thank you very much, Dr. Swanson. This is Jessica Engel from Intern Year. It was absolutely fascinating, and you really incorporated so many things from, traumatic brain injury to your military experience to lifestyle medicine, which I think is becoming a huge, huge part of how we are practicing now as physiatrists, and we're taught to treat the whole body. And even, some of us, even, from the first day we started medical school and osteopathic medical school, that, as you said, the body has the ability to heal itself. And I really appreciate this lecture. Is absolutely phenomenal, and you hit it out of the park.
Well, thank you very much for your kind words.
All right.
I think we have a lot.
Go ahead, Jessica.
I was going to say, I think we have a lot that we can help share with our patients to make a difference, even if they come in for something as small as a one joint musculoskeletal issue that we can, even from this talk, we can bring as far as a lifestyle medicine component and making a big difference for the rest of their lives, and especially with the traumatic brain injury patients. This is great. Thank you.
Yep, absolutely.
Well, it is 1:00, so thank you again. And we really appreciate you giving a presentation of all of your interesting work. Have a great day, everybody.
Thanks. Bye-bye.
Take care.